All right, we were recording now. Let's see. All right, I got your message, Allison. And who just joined? Nishit, okay. All right, the concept involved in hematologic disorders is perfusion. So there are different functions of the cardiovascular system. Cardiovascular system, of course, delivers the oxygen and nutrients throughout the body. The actual carriers are the hematologic system. So hematologic system covers all blood cells. So this will also cover all blood cell disorders of the red blood cells, the platelets, and the white blood cells. Not all disorders stem from the bone marrow, but most of them do. It may not stem from a bone marrow disorder, but eventually it will. Such as, for instance, when you go to cancer, when you receive chemotherapy, the number one complication of chemotherapy is bone marrow suppression, or we call that myelosuppression. So there can be direct or indirect damage to the bone marrow. So the bone marrow major function is to produce all three types of blood cells. So we have the red, white, and platelets. So if we, there should be a figure, right? This one. Okay, so this is a common figure used to explain the development of the blood cells. So all of them come from the same stem cell. So upon conception, we all came from one pluripotent stem cell, and then one of those during cell division and differentiation, one of the stem cells became the bone marrow. So from that one stem cell, we have differentiation into erythroblasts, myoblasts, monos, and so on. So when we talk about leukemia later, myeloid stem cells, therefore, mature to become your red blood cells and your platelets. If you follow this diagram here, whereas lymphoid or lymphocytic stem cells mature to become white blood cells. Okay, so this will give you an idea about what will be the effects of what type of leukemia you have, for instance. So when we say um, the patient has acute or chronic myelocytic leukemia or myeloid leukemia, for instance, so that means the defective stem cell is the myeloid type. Whereas if it's lymphocytic leukemia, the affected stem cell is the lymphocytic or the lymphoid stem cell. However, the signs and symptoms will be very, very similar. The patient, regardless of myeloid or lymphocytic leukemia, all end up having the same symptoms, namely, they will present with anemia, thrombocytopenia, and leukopenia. The reason is they are all made from the same bone marrow. My point is, even if it's only a myeloid leukemia, for instance, which will mature to become these cells right here, and or versus lymphocytic, for instance, since they are in the same bone marrow, and the characteristic of cancerous cells is they have no control, meaning the suppressor genes are not working. Nothing is stopping them from overgrowing. Since they are located in the same bone marrow, they will end up crowding out even the normal stem cells. Am I making sense? Let me Okay, so let's say this is your bone marrow, and then you have lymphoid stem cells there, you have myeloid. Okay, so let's say it's a lymphocytic leukemia, and let's mark these guys as stars. Okay, so let's say this one is lymphocytic leukemia, so they will multiply uncontrollably. Okay, so they will now crowd out the entire bone marrow. So therefore, even though you have normal myeloid stem cells, because of the proliferation of the lymphoid leukemic stem cells, they will end up occupying the whole area, thereby leaving less room for the normal myeloid type. So even though technically the patient's symptoms are supposed to be only low white blood cells, because the lymphocytic leukemia is, of course, this type of stem cell mature to become WBCs, the myeloid becomes suppressed because of the crowding out inside the bone marrow. So therefore, the patient ends up being low on all three blood types. And then we can say the same if the problem were the other way around. Does that make sense?
Yes.
Okay.
Yes.
All right. So let's go back to textbook. Okay. This is just a review. Plasma, I'd like to explain it by diagrams. Okay, so I'll use this one instead of the paragraphs. So our blood has two parts. We have the plasma part, which is where all your blood cells and all the other substances that are inside your blood are suspended. So when we take a blood sample, put it in a test tube, and spin it in a centrifuge, you know what a centrifuge is, right?
Mm-hmm.
Yeah.
Yes.
Okay.
Mm-hmm.
So when you spin it, so of course by gravity, it will separate the blood components. So now when we look at what is your blood composed of, so we have the formed elements, which are all your blood cells. So we have your red blood cells, we have white blood cells, platelets. Other solutes are these tiny, small amounts. And then it's mostly water, 91% water, but because there's proteins in the plasma, that water stays in the blood. It cannot go to the cells um, easily. Okay, so the plasma commands a certain amount of water in it because of the osmotic pull of the albumin of your proteins. So that's the right there. So the proteins is mostly albumin. Okay. Now, so what does it say when you open your patient's blood results? So let's say you open the CBC and it shows a total WBC count of 20,000. And it says here that your white blood cells should only be between 5,000 to 9,000. What is the significance of a 20,000 total white count?
It could be a blood disorder related.
Can you be specific? Okay, I'll put it in a test question. The nurse examines the patient's blood result, CBC result. It shows hemoglobin of 13.5, hematocrit of 42%, red blood cell 5.8 million. Platelets are 250,000, and the total white blood cell count is 20,000.
Could it be an infection?
What will be the nurse's conclusion? Yes, Tasha?
The
Hello?
patient has an infection.
Okay, that's a possibility. However, we need to know the breakdown of the white blood cell count, because out of the 20,000, or in this case, 5,000 to 9,000, this is the breakdown. This is the normal breakdown of your leukocytes, meaning we have different types of white blood cells, not just neutrophils. So each white blood cell type responds to a certain invader. So these are the normal percentages. That's why this is percentage, because this is what makes up the total number. So meaning, let's say if we have 20,000, and this is it should be broken down in a simple CBC, a routine CBC. It won't give you a breakdown. Have you seen it in when you were in clinical, during the time that you did get to go, wherein there is a complete blood count, but there's also a CBC with differential? Have you seen that blood test?
Yeah, not in a clinical session, but
Okay, so when it says differential, that costs more. That is a little bit more expensive test because it requires more work. Not only is the lab scientist only estimating the total number, but the lab scientist has to break down, well, how many of that, what percentage of that 20,000 are neutrophils, lymphocytes, monos, eos, and basos. Okay, and then there are two subtypes of neutrophils. Neutrophils can either be segmented or band neutrophils. So they're all explained here. Leukocytes is the overall umbrella. All white blood cell counts are called leukocytes. Then we have lymphs. Tells you here what is the function of lymphocytes. They kill what?
virus infected cells.
Okay, so therefore lymphocytes are increased in number when you have a viral infection. Whereas EOs, what do EOs, when will EOs number increase? In what type of condition? We have here allergic, or also in parasitic infections. Then the same thing for baso. So when do you have an increase in basophils? These are also seen in allergic and inflammatory reactions. So it's not always, you can't really say that because the patient's total WBC count is increased, that doesn't mean they're experiencing an infection. Is that clear? Hello?
Yes, Professor.
Okay. So please read these on your own for class. Um, uh, uh, Recognize what each type of white blood cell is used for. Meaning, when are they considered? When are they increased, and in what condition? I want to show you the neutrophils. Okay, here. Neutrophils can either be segmented, which are mature, or they can be bands, which are immature neutrophils. You read the news, right? You've seen documentaries about terrorist organizations like Al-Qaeda or the Taliban, for instance, wherein do they use grown soldiers to go to war? I mean, are they all above 18? Or those you see in Sudan also, terrorist groups in Sudan? Yeah, no, do you know what I'm talking about?
No.
Oh, okay. Terrorist organizations use child soldiers, okay, because they don't have anyone else. So they use whoever they can, as long as they can carry a gun, and then they can shoot. Okay. Same thing in the body. When you are desperate, so for instance, when a patient has a severe bacterial infection, wherein you don't have enough mature neutrophils in order to go to battle, go to war, the body ends up releasing banned neutrophils, which are immature neutrophils, meaning they are not capable of really fighting the infection effectively. However, since they are still neutrophils, they are still capable of phagocytosis. So you can say it's better than nothing. Does that make sense? So in the presence of a bacterial infection, wherein the patient has symptoms, the patient looks sick, you will see an increase in banned neutrophils. Okay, so and that signifies that the patient's immune system is overwhelmed, meaning that is evidence that the patient needs treatment. Does that make sense?
Yes, Professor.
All right, so this is now your proof. So when you see another term you'll see in clinical is either a left shift, and there's a long story why they call it left. I'll talk to you about that another time. Or they'll say bandemia. So a left shift or bandemia is indicating bacterial infection. When we talk about anemia, there are generally three causes of that can lead to anemia. One is, which is the most common, is a decrease in the production of red blood cells. Second is an increase in red blood cell destruction. Third is acute or chronic blood loss. In the case of decreased red blood cell production, the problem there could be nutritional, meaning the patient just has a poor diet. Their diet doesn't have enough folic acid, iron, B12 needed to to make blood cells, because these nutrients are necessary in order to form red blood cells. Another possible cause is, although their nutrition might be rich in all these nutrients, meaning their daily diet is really healthy, they have enough iron, they have enough B12 and folate. However, they have the inability to absorb it, either physiologically, meaning they don't have a well-functioning GI tract, for instance, or they've had partial or total gastrectomy, or they could have they lack other nutrients. For instance, what have you learned? What do you need to take with iron in order to absorb it?
Vitamin C.
Vitamin C. So that's an example. Same thing. What do you remember from A and P? What enzyme do you need in order to absorb vitamin B12, which is produced by the stomach? What is that enzyme? Let me see if it's here. Right here. There's a enzyme located in your, produced in your stomach, which is called the intrinsic factor. So this might not be present anymore if the patient experiences or undergoes partial or total gastrectomy, because this intrinsic factor is only produced in the stomach. So if the stomach is gone, either totally gone or you have half a stomach left, then you don't either have no intrinsic factor or not enough intrinsic factor in order to absorb B12. And as a result, even though you have lots of B12, you cannot absorb it. So for these patients, under chapter 30, this will be called pernicious anemia. Since they cannot absorb it by mouth, then the B12 will be given parenterally. So for life, the patients will have to require vitamin B12 injections once a month for the rest of their life. So that's an example. So that covers in decreased red blood cell production. Another problem is increased red blood cell destruction. So you may have a condition called, have you heard of sickle cell anemia?
Yeah.
Right, so you'll cover that under chapter 30. These are genetic disorders wherein the patient's red blood cells sickle. So this is the normal shape of your red blood cells. They're nice disc-shaped cells. They have no nucleus, so no nucleus, so therefore can they divide? No. So they are solely produced by the red blood cell, the bone marrow. So on their own, they cannot really replicate. Okay, so they have no nucleus inside these cells, which is also good because no nucleus, then that means these red blood cells are also very flexible. So they can, let's say in around joints, for instance, wherein you have traffic there because of the, there will be some skinny vessels there. They can squeeze through that, no problem. So that their shape allows them to be very flexible. However, in sickle cell anemia, they have a faulty gene that causes these red blood cells to sickle, meaning the shape will now be a crescent shaped. Because they're no longer disc round shape, they are now sickled like a half moon shape. The triggers you learn in chapter 30 that these are triggered by hypoxia, hypoxic episodes, like if you smoke, you have the flu, you have the pneumonia, or you have you're at a high altitude. So anytime your oxygen levels drop, that will trigger the sickling of these hemoglobin. As a result, they will obstruct blood flow, and because they are sickled, they can no longer carry oxygen. So that's the nature of sickle cell. So that falls under increased red blood cell destruction because these cells are no longer going to have the normal lifespan, which is 120 days. So the patient experiences anemia. Another example is Polycythemia Vera, which is also under chapter 30. In that condition, the patient has an abnormally high amount of red blood cells. However, these red blood cells are not normally shaped. They are immature, and so they do not have the regular lifespan, which is about 120 days. So as a result, the patient still has anemia. So those are two common examples of an increased red blood cell destruction. The third is acute or chronic blood loss. There are many causes for that, and those are all again under chapter 30. Not only in chapter 30, but also in other chapters under peptic ulcer disease, which causes GI bleeding, and also in DIC, which is under the sepsis chapter or under the shock chapter. Oh, you guys already talked about shock, right? You covered shock already in exam 1 or something?
Yeah.
Yes.
So you know DIC, right?
Yes.
Yes.
Okay. All right. So that's for anemia, and then now let's go to thrombocytopenia or bleeding disorders. Before we go into that, let's cover this one. You still remember the how the body forms blood clots? This figure right here. Yes, no. Okay, I'll assume it's a no. Just a short video. All right, let's watch this video, and this will be helpful for us when we go to DVT prophylaxis and management.
At the site of vessel injury, the first platelets arrive to start sealing the wound. Simultaneously, the coagulation cascade with its various coagulation factors is activated. This involves two pathways, the extrinsic and the intrinsic pathway. Extrinsic activation begins with now exposed molecules of the vessel wall, such as tissue factor, which forms a complex with factor 7. Finally leading to the activation of factor 10. This factor 10A is the point at which the extrinsic and the intrinsic pathways of the coagulation cascade meet. The intrinsic pathway consists of various coagulation factors activating each other in a chain reaction. At its end, a complex with an additional cofactor is formed. This complex now activates factor 10. Since the two pathways merge at the level of factor 10A, this factor has a pivotal role in the coagulation cascade. Further down the cascade, factor 10A, in combination with 5A, activates thrombin and induces the so-called thrombin burst. One molecule of factor 10A can catalyze the formation of 1,000 molecules of thrombin. These large amounts of thrombin cause the further activation of platelets and the enhanced formation of fibrin. Fibrin then forms strands, making up the mesh that stabilizes the platelet plug in an arterial clot and holds together the red blood cells in a venous clot. It can be concluded that the central role of factor 10.
All right, so let me explain what you just saw. All right, so the video talked about the two pathways. To illustrate the example, who has had a cut lately? Who among you had a, I'm not saying a needle stick at work, but let's say pricked your finger or had a paper cut. Doesn't have to be yesterday or today. No, recently. You remember? Nobody ever had a cut at all, or
I've had a cut before, but not recently.
okay, yeah, that's perfect. Who's that?
This is Tasia.
Okay, Tasia. So as much as you can remember, what was that? Was that a paper cut or was that a scratch?
I had an incision, surgery incision.
Oh, okay. Well, that was surgery,
That's
so
big.
that would be different. Okay, maybe. Okay, so let's see. As far as you can remember, did it bleed at all?
Yeah, not a lot, but yeah.
Okay. So let's imagine it wasn't a surgical incision. Okay, so let's say it was a paper cut or somebody got stuck with, I don't know, a fish, the bone on a fish. Okay. The moment we got stuck with that sharp object, naturally it bled, right?
Yeah.
Okay. Now, did it bleed nonstop?
No.
No, eventually it stopped, correct?
Uh-huh.
However, did it remain like that, or did it bleed again after a couple minutes?
Uh,
After you washed your hand after an injury, right? So after you wash your hand, did it bleed again?
just a little bit. It
Oh,
don't like start pouring out again, but you do see
all right. So that
it
that will
again.
illustrate our clotting cascade here. So the moment a vessel, it could be a capillary, an artery, a vein. The fact is that the vessel was injured, so that's why you bled. Every damaged capillary, which is present in tissue, will release tissue factor. Now, this tissue factor will activate the whole clotting system. The extrinsic pathway, which is shorter, as you can see here, the demonstration here is very short. It stops at factor 10. So it only has one, the injury, and then 2, 3, 4. That's it. They form a clot. Okay. So as soon as factor 10 is activated, then that will invite platelets in order um, to stick to the wound, and then another, once the platelet is stuck there, another platelet comes along, gets stuck to that platelet, and then more platelets gather, more and more platelets, and then they plug the wound. So that explained why the bleeding stopped. However, since that wasn't a fibrin clot, meaning it wasn't a stable clot, it will bleed again, especially if you touch it. If you move it, it will bleed because that was a very unstable plug or a temporary clot. Here comes the intrinsic pathway now. Now, the activation occurred exactly at the same time. However, because the extrinsic pathway was shorter, it was faster. It was, however, a very unstable but an emergency plug nonetheless. The intrinsic pathway will now create a more stable, longer lasting clot. So as shown on the video, this will involve a series of activations. So one factor will activate another factor until factor 10 is also activated. And as you saw on the video, factor 10 together with factor 5 will now activate, change prothrombin, turn it into thrombin. And once thrombin is now activated, then you have fibrin formation. Now these strands you see here are now the fibrin strands. So when they hold the platelets and red blood cells together like this, that is now called a fibrin clot. Okay, and now this is now a much stronger clot, a more stable clot, so this will permanently stop the bleeding. Are you with me so far?
Yes.
All right.
Yes.
We'll go back to this when we get to DVTs, which is the same management as a pulmonary embolism. DVT, I'm talking about deep vein thrombosis or deep vein thromboembolism, because the treatment will be based on the clotting cascade, meaning the drugs that we use, the anticoagulants we use, act on the clotting cascade, meaning they try to disturb the clot at different points. So for instance, we have anticoagulants called 10A inhibitors. So they work right around here. Okay, they stop 10A from being activated. We also have heparin, which is an indirect thrombin inhibitor right here. So heparin acts right around here. And then of course we have the very popular warfarin, which has nothing to do with the pathway, which I'll discuss later when we get to chapter 37. Are you following so far? You guys are still with me, right?
Yes.
Alrighty.
Yes, Professor.
After the platelet plug is formed, meaning you have a clot, the next step is now clot retraction and dissolution. So this would explain why later when we talk about blood clots, a DVT or a pulmonary embolus or an MI or a stroke, all caused by clot, it's not always treated with thrombolytics, meaning it's not always necessary to give a clot busting drug because the body destroys the blood clot naturally anyway, meaning after all of this, after the clotting cascade, at the end of the cascade, right here, the next step once a clot is formed is this now. The body will naturally retract and dissolve the clot naturally. However, this involves a long period of time. This will take several hours to several days, which in some of our patients, we don't have that much time, meaning we don't have that luxury of time. So for instance, if the patient has a blood clot obstructing the left anterior descending coronary artery, do we wait for the body to naturally dissolve the clot? Can we say, oh, don't worry, according to the clotting cascade, after that clot is formed, the body will dissolve that? Can we say that?
No.
No, because the patient will die by the time the body dissolves that clot, right? Same thing for a stroke, same thing for a pulmonary embolus. So there are certain conditions, acute conditions that require us to intervene sooner, okay? And then we can't just leave everything to the body. One of those products, by the way, when you degrade fibrin, so we have a fibrin clot right here, okay? So now you have that stable fibrin clot. When you dissolve fibrin, you're left with fibrin split products. That fibrin split product is called, one of them is called D-dimer. Have you heard of D-dimers?
Yes, Professor.
Yes.
Okay, all right. So the fibrin split product is, a D-dimer is a fibrin split product, meaning it's a byproduct of fibrin degradation. So therefore, when the body starts dissolving the clot, what's left of it is D-dimer. So therefore, if you have a D-dimer level of more than 250, which is now abnormal, then what's the only explanation? If you have a high D-dimer, what did you have?
A blood clot somewhere.
All right, you had blood clots because that's where they came from. Meaning that's the only explanation. However, you can't use a D-dimer to make a diagnosis though. However, it does help support diagnosis, but you can't make a diagnosis simply based on D-dimer. Okay, there are other tests which we'll talk about shortly. Lymphatic system, the other organs here, please read on your own. So we have the vascular system is, there are three. We have the arterial, the venous, and the lymphatic system. Okay, all circulating. Well, the lymphatic system doesn't circulate blood, but they do circulate your white blood cells straight from the lymph nodes. Okay. Okay, that's nice to know. All right. There are different factors that will affect red blood cell, platelets, and white blood cell numbers. One is the liver. As far as clotting, of course the liver does what? What is the major role of your liver in blood formation or in hematology? Have you been in pediatrics clinical already? Or
I
in
haven't.
newborn?
No, Professor.
No? Okay. Um, have you heard that we administer vitamin K injections to newborns?
Yes.
Okay, so let's go with that. So why do newborns receive vitamin K?
In case they have a clotting disorder. It's a prophylaxis.
Okay, why babies though? Why are they given automatically?
They're not born with when they're born, it's not they don't have that ability as yet.
All right, because what is their liver status? Is it mature? Are their liver is their liver capable of making clotting factors at birth?
No.
Not yet. So because of that, all babies receive vitamin K injections. Who is this phone number, by the way? I'm just checking attendance.
That's Louise.
Oh, Luis. How are you, Luis? Long time no see. So 7, okay. All right, so if you have liver problems, namely hepatitis or cirrhosis, that will affect liver function. So therefore, hepatitis, especially cirrhosis, will involve bleeding disorders, okay? Because of the function of the liver, which is to make clotting factors. Medications, you are aware of drugs that will cause bleeding. We have direct drugs known as anticoagulants. We have warfarin, which is a vitamin K antagonist. We have heparin, either unfractionated heparin or low molecular weight heparin. Both are indirect thrombin inhibitors. All are anticoagulants. And then the third, of course, we have novel oral anticoagulants. We'll cover all those next. These are other factors which we kind of mentioned already earlier. So this will affect it again. So what about if you have a patient who had gastric surgery for purposes of weight loss? Will they have anemia as a result? Yes, right? Although the approach nowadays is not to remove the stomach, but just to put it in a sleeve, which is now the trend, because they don't want the patient to lose the intrinsic factor. So instead of removing the stomach surgically, they will just reduce the size of it in order to for the patient to lose weight. Nutrition, we already discussed at the start of the class. So these are the nutrients that you need in order to develop red blood cells. And these are the sources for each one. So in case you get a question on the exam saying which menu or what foods will you teach the patient to increase, and that could be for iron deficiency anemia, or B12 deficiency anemia, or pernicious anemia, or folic acid deficiency anemia. Okay, elimination. This is related to blood loss, either acute or chronic blood loss. So started here actually, if the patient is vomiting blood or if they are pooping blood. So black tarry stools indicates upper or lower GI bleeding.
I think it's lower.
If it's lower, then did it have a long time or a short time to get to the rectum?
A long time.
Well, you say lower, then that means it will start in the colons, in the large intestines. Upper GI bleeding starts from the esophagus down to the ileum. That's the upper GI tract. The lower starts from the cecum down to the sigmoid. So if the stool comes out black, did the blood have a long travel or a short travel?
Long travel.
A long travel. So black tarry stools indicate upper GI bleeding. If it's more red coming out, either bright or dark red, that is still indicating lower GI bleed because they had no time to decompose or they had less exposure to acid. Is that clear?
Yeah.
All right.
Yeah.
Okay, activity exercise pattern. We know that patients with anemia will have activity intolerance, so they may not have the energy to carry those out. So assess for these. Okay, that will be indicative of anemia or any other blood disorder. Sleep rest pattern, because of course the less sleep you have, that will indicate anemia as well. I mean, it's really vice versa. You can't sleep, then you'll have low red blood cell count, and then vice versa. Having anemia also causes fatigue. These symptoms here are seen in chapter 30, particularly under sickle cell disorders. These questions here, by the way, I don't know if your instructor is Dr. Fox, right? Okay, so I don't know if she will use these on a test question. These are common assessment questions you will use in order to assess if the patient has hematologic problems. Okay, so they come from, like asking about their history, their lifestyle, smoking or alcohol consumption, nutrition wise, if we are seeing, trying to see whether or not it's a nutrition issue that's causing the anemia. And then same thing, if they have bleeding, it is usually seen depending again if it's upper or lower GI bleeding. So these are questions. Okay, so just read through those. I mentioned
Hello?
oh, hey, Zishan.
Yeah, Professor, I don't get any of your emails. I actually emailed you like an hour earlier.
Mm-hmm. Okay, what I'll do moving forward is, can I ask everybody to send me an email? That way I don't email you through Blackboard, and then I'll
Okay.
just email you straight from the MAC email. All right, so just send me a hi, hello, or I hate you email. Okay, so just so I can have your email on file.
All right, I'll do that right now. And Debbie's here. She just didn't get the email as well.
All right, we'll wait for Debbie should be coming.
Professor Louis asked me to let you to tell you that she can get herself to unmute.
Who is?
Louise.
Who?
Louise. She called in. She said she can't get her phone. She can't get it unmuted for her to speak. But she's in class.
That was you're talking about Louise, right?
Yes.
Yeah, I unmuted Louise already.
Hello?
Yeah, hello? Is this Louise?
Oh, Professor, you can hear me now?
Yes.
Because I was trying to speak earlier when you spoke, but I don't think you were hearing me.
Yeah, I wasn't.
Oh, okay.
I can unmute you. You
Okay,
should be
Professor.
able to do that too. You're on your phone, right?
Yeah.
Oh, okay. All right. If you have questions, just put it in the chat box because I get the alert that there's a message
Okay.
like right now. Okay. John's here. All right. You know that. Where were we? Okay. My last question was: did you see clubbing of the fingers somewhere, especially for exam 2 or your midterm under respiratory? Do you recall finger clubbing?
Yeah, late stage.
Right. So finger clubbing indicates chronic hypoxemia, which is not only seen in chronic respiratory disorders, but also in chronic anemia, because it's really the same. This is now oxygen transport. So if this one, though, did not result from a respiratory problem, it's a problem now with oxygen transport, meaning because you have less red blood cells to carry oxygen, then you have the same peripheral hypoxemia here. So the periphery, specifically the fingers, will now suffer hypoxemia, meaning less oxygen, less perfusion, so therefore the fingers will club. Just scrolling through these are nice to know. Right, with white blood cell disorders, we are talking about leukemias or lymphomas here. These are now disorders of the white blood cells. The nodes shown here in figure 29.6 are the areas wherein you will feel or palpate lymph nodes. Normally, lymph nodes should not be palpable. When they are palpable, that means they obviously are enlarged. They are enlarged in infections, but in non-infectious conditions, which are, we're talking about leukemias or lymphomas, or in HIV, for instance, wherein HIV has lymphadenopathy. So these are also enlarged in those conditions. You're aware of signs of bleeding. These will be mentioned in chapter 30.
PA, edemosis, all that, yeah.
Yeah, so petechia are the pinpoint dots that you see, kind of like when you have a day-old mosquito bite. After the swelling comes down, the mosquito bite still has a remnant of a pinpoint red area, so that's what we call petechia. However, in bleeding disorders, so let's say in chapter 30 you talk about immune thrombocytopenic purpura, for instance, or ITP, or thrombotic thrombocytopenic purpura, or TTP. These are in large clusters, though. So when you put all of these tiny petechia together, when they're so close together, they may form an ecchymosis now, or what we call bruising. But regardless, these are all indicating bleeding. Okay. The size, of course, will range from microscopic bleeding, which is your petechia, and then you have larger bleedings, which are called ecchymosis. Angiomas are different. I've never seen a person with angioma here in this country. this is quite common in Asia. We have people who develop angiomas. This will be, of course, obvious because they occur either on the face, the neck, and the arms, sometimes on the torso. Some of them are raised. Okay, it's just unsightly, but nothing really serious. Okay, because they're benign tumors of the blood vessels. Purpura are seen in the elderly. You've probably seen them, especially if the elderly patient is on blood thinner or even just on aspirin. So you'll see them right underneath the skin. It's not the same as an ecchymosis. It's much more benign compared to an ecchymosis. Okay, let's look at your lab work now. All right, so again, when you're indicating bleeding, these are some of the assessments that you'll be looking for. Assessment findings. For labs, these are routine labs. We have blood counts. At the start of the class, I mentioned the differential. They're the same CBC, or CBC would be just the total white count. Whereas when you say CBC with differential, or sometimes they'll order this separately, white blood cell count with differential. Either way, the differential will break down what that total white count is made of, into neutrophils, lymphocytes, monos, eos, basos. Clotting studies, which are routine in patients going pre and post-op, especially pre-op, we'd like to see their clotting times first before we put them under the knife. And BP changes, of course, what do you expect the pulse rate to be if they have anemia or bleeding? That will be high, correct? And then you just recently had, no, you haven't tested yet on cardiac, correct? What is one of the causes of sinus tachycardia? As far as hematological disorders are concerned, anemia was one of them, correct? Anemia can trigger sinus tachycardia as well as dehydration or hypotension, which is present in when you're bleeding. If you haven't already, please memorize your blood counts. I doubt if your exam questions will give you an interpretation, meaning Dr. Fox won't put a question saying the hemoglobin is low or the hematocrit is high. She will give you just numbers, just like in clinical.
Yeah.
So she'll give you the patient's lab values, and the question will either be an assessment question or asking you to do something, an intervention. Are you guys collecting information? When I went to school, I had something, a clinical, what did we call it? I think we called it a clinical tool. So as we went through from one semester to the next, there were certain numbers that we add to a document. So for me, it was a notebook, because we didn't have computers at that time. So I listed down the values, and then I became more familiar with them. They were mostly the CBC, the BUN creatinine, and then the clotting time. So I had to be familiar with those, not only for clinical, but for exams. So it wouldn't hurt if you created one and just add to it every time you finish a semester. We'll look at these numbers when we get to chapter 37 under DVT and management of DVT. We're almost done with this chapter. Blood compatibility. This one has to be memorized. No other way around it. Which one is a universal donor again?
Should be, say O.
All right, O. As we can see, it's compatible with so many blood types, all of them actually. So here, what about the who's the universal recipient?
So that's AB.
Okay, that's A. When it comes to Rh negative people, the one you really worry about are the Rh negative individuals, meaning they don't have the antigen present on their blood cells. So therefore, when they receive Rh positive blood, they will have a hemolytic reaction, which is fatal. However, if they receive an Rh positive blood for the first time, they won't die during that transfusion, not during that one, because they haven't been exposed or sensitized yet. However, after that first exposure, since now they developed antibodies against it, the next time they receive it, then they'll have a reaction. On a test question though, unless the test question specifically says that the patient has never been exposed or has never received an Rh positive blood before, if that information is not on the test question, then assume that the patient has been previously exposed and therefore has antibodies against it. Any question regarding what I just said?
I think I got it.
All right, very good. These are numbers again. So bilirubin, maybe not for this exam, but when you go to liver disorders, liver cirrhosis, hepatitis, you will use this number now, bilirubin, but probably not now. The Coombs test, I mean the direct and indirect Coombs, these are significant in maternity and newborn, because that's when those problems really arise. A Rh positive mom gives birth to an Rh negative child, or vice versa. All right, that's it. Let's go straight to 37. Any question, by the way?
No.
All right, very good. Okay. Okay, blood clots. Who do you screen for the risk for DVT development?
Your immobile patients.
Okay, that's one. Let me give you a clue. These three here is known as the Virchow's triad. Virchow's triad is mentioned here, this one. There are three factors meaning number one, venous stasis. Venous stasis is any condition wherein blood flows in one area of the body. That blood may be pooling either in the periphery, so let's say in your lower legs, or they could pool inside the heart or elsewhere. So the conditions that lead to venous stasis are the following: obesity, pregnancy, heart failure, AFib, people who travel, take overseas flights, so let's say a 16-hour flight to Hong Kong, for instance, or have a prolonged surgical procedure, or have, let's say, spinal cord injuries, wherein they ended up being paraplegic, either paraplegic or quadriplegic, or are in a coma. So anyone who have increased period of immobility, either brought about by their condition or a procedure, for instance, there will be venous stasis. Another factor is endothelial damage, meaning there is damage to the vessel. This could be one or more vessels, capillaries, arteries, or vein, doesn't matter. There is vascular injury or there is endothelial injury. And the video you just watched earlier about the clotting cascade, remember the tissue factor? So once there is vessel injury, remember that the tissue factor will be released by that injured vessel, and the tissue factor triggers the clotting cascade to begin. Then finally, hypercoagulability. By the term itself, hypercoagulable, meaning these are conditions that increase the body's likelihood to form clots. Those conditions are here: women who smoke and or take OCPs or oral contraceptive pills, have a history of a blood clot in the past. These are the conditions that, or some drugs here, specifically on steroids, specifically long-term steroid therapy. So this would be autoimmune disorder patients, patients with inflammatory conditions, lupus, arthritis, multiple sclerosis, right? So those chronic conditions that require, or even COPD patients, right? Or asthma patients who are taking steroids, or those who receive solid organ transplants, wherein they're taking steroids to prevent organ rejection. So all these doesn't have to be all three, any one of them. So back to the question again, where Zishan said one of the factors, which is venous stasis, one of the Vercro's triad. So looking at this again, what will be your answer now? Who do you screen for DVT prophylaxis? Which patients?
Your obese clients.
Only obese patients?
No, your obese clients, people with that neuromuscular disease. What did you say? On multiple sclerosis.
Yeah, so it could be Guillain-Barré. So only those people that are sick?
No.
Everybody.
Pretty much everybody, because I'm
Really
sure.
everybody. So the
Yeah.
answer is screen everyone admitted to the hospital, because they may not have this on admission. So let's say, Tasha, do you identify with any of these work I had mentioned here? Do you have any conditions? I mean, right now. Okay, I'll assume Tasha's answer is no. However, when I put you in a hospital, will you have these now?
I feel like you can.
Yes, because now, if let's say, for those who have ever been hospitalized, have you ever been in a hospital and then you walk around the hallway, in other stations, or are you stuck in bed playing with your phone?
you're going to stay in one place for a really long.
Exactly. So that changes your routine, meaning even if you didn't have them on admission, you will have one or more of the Vercostria during your hospitalization. So that's why all patients must be screened for DVT prophylaxis. Now, what is in a DVT screening tool? So it's this one, Table 37.8. There's really no standard tool. Each hospital ends up creating their own, but it's not hard to do. Like this one, if I were asked by the medical board to create one, can you create a tool, please, for risk DVT risk assessment? What I'll do is just copy and paste all these in table, what is it, 37.8, and then put it in a table on a Word document, and then that's it. That's my DVT assessment tool, risk assessment tool. So what I'll do is assign points here. You only need 2 points in order to qualify for, meaning to be at risk for DVT. Look at this. So let's say I'm old. I'm 65 or older. That's 1 point already. Or let's say I smoke. Where, right here, tobacco use. So that's 2 points already. So is it easy or very hard to have an increased risk for DVT?
It's pretty easy.
Pretty easy. It's very easy to score 2 points, right? So let's say you came in with pain to the hospital, abdominal pain. So we don't know what you have, but you don't smoke, you're not obese. But however, the fact that you have reduced mobility because you are in pain, so you're not likely to be walking around. So that's already 1 point right there, right? So it's not really easy. Plus, you're not drinking very well, for instance, because we're keeping you NPO because you have a stomach ailment. So that's standard that we don't feed you. So that means you could be dehydrated. So look at this. That puts you in a hypercoagulable state because you have dehydration. That means your blood has less fluid in it. That means your blood concentration is high. So it's likely for blood clots to form. So you can go down this list. So this would be pretty much your risk, DVT risk assessment tool. Any question?
Nope.
All right, so that covers our DVT risk assessment. There are 2 types of DVT. DVT, VTE, these are just different terms. DVT is deep vein thrombosis. VTE is venous thromboembolism. Means the same thing. Superficial vein thrombosis, as opposed to deep venous thrombosis, doesn't mean that superficial is less risky. Actually, it still is, because if not, if you don't eliminate the risk factor, or you don't do prevention measures, the superficial vein thrombosis can advance and become a deep vein thrombosis, meaning this thing can dislodge and end up inside a deeper vein. As a result, from there, the patient could develop either a PE, an MI, or a stroke from there. Okay, so a tiny little object can kill you. In fact, 80% or more of the patients that you see dead, let's say you walk into a patient's room, right? On a non-telemetry floor, you walk in and the patient's already dead, chances are they develop a PE. Because it doesn't take much for a deep vein thrombosis to become dislodged and become a traveling clot. And from there, they can obstruct smaller vessels, which is usually the lungs get it first. Why, now, aren't you curious? Why is it a PE? Why not a heart attack or stroke? Why does the clot end up in the pulmonary artery?
I think because of the pressure there.
Well, if you review physiology, let's say I'm a blood clot, okay? So Mr. Carter is a blood clot. I came from your left leg. So trace my journey into the heart. So from the left leg, let's say Z shape, to trace my journey, why would I end up in the lungs first?
So I'm guessing it's probably following the oxygenated blood.
All right, so I return to the heart, right, via the inferior vena cava. And
Yeah,
then from there, where do I go?
goes into the heart, goes, I think, right atrium,
Yeah, that's right.
right ventricle, all the way up to the pulmonic valve, and it goes all the way to the arteries.
Okay, so now I reach the lungs first. So I don't reach, technically I enter the heart, but I did not enter coronary circulation until I left the aorta, correct? So
Okay.
that's why the first complication will be a PE. So that's what will kill the patient first.
Okay. Makes sense.
We'll discuss PE another time. Let's discuss how do you diagnose a DVT? You have signs and symptoms here. Oh, by the way, let's do prevention first. So we know the varicose triad. We have venous stasis, we have um, hypercoagulability, and what was the third triad? Endothelial injury. Okay, so I had surgery or I had trauma. Okay, so I had vessel injuries. So what does this say here? How do you easily prevent a DVT? Early and aggressive mobilization. So that's why you see, if you ever had a patient who is post-op, when do we get the patient out of bed and up on their feet?
As soon as possible.
Right. So we get them out the same day. The only exception is open heart surgery. Open heart surgery are taken out of bed the next day. But all others, especially orthopedic patients, hip, knee, shoulder surgeries, are gotten out of bed on the same day. They usually do the same. These are first case patients. They go early in the morning, and then so they're back by lunchtime in their room. So they're out of bed by the end of the day. The physical therapy comes in, takes them out. They can whine like babies. No, I'm in pain, but they don't care. The PTs get them out anyway. Of course, we give them pain medication. But because these patients are very high risk for DVTs. Um, Others are stockings, um, or these compression devices right here. You know, PCDs or SCDs, right? You've seen them, you've applied them on patients. So why these? Why ambulation? Why stockings? Why compression devices? What are all these things trying to do? So compare it back to the Burkos triad. So we have these three here causing the likelihood of a blood clot formation. So what are these prevention interventions doing? I mean, we can't help it. They had surgery. So they have the one of the triad already. They had endothelial injury. And they have venous stasis because they have decreased mobility. So what will these activities do? You know, ambulation, stockings, and these compression devices do, Miss Jennifer?
Increased circulation.
Or Zisha? Oh, very good. So they
I thought my mic was on. My bad.
return, right? So that's what we are trying to do. We don't want blood pooling in the periphery. We want to, because what's the only way blood returns to the heart? No problem with arterial circulation. We have the heart pumping the blood. But the problem comes with on its way back. How does the blood return to the heart? We don't have a second heart down in the feet. Blood back up. So what's the only way blood returns to the
heart? The inferior vena cava?
Well, that's where they empty. So how does blood return? So let's say you're standing right now. How does that blood go back up to your heart against gravity?
What was it? By movement.
How is that possible?
Is it by movement?
All right, through muscle contraction. So unless your muscles are contracting, blood cannot return. So therefore, what are these things doing again? Ambulation, compression stockings, compression devices. What do they do?
It's causing you to use your muscles with the ambulation.
Right. They're squeezing the muscles. If you're not moving your muscles, these things, these devices will squeeze the muscles. All right. So ambulation does that easily. So if you walk, muscles are contracting, they're squeezing the veins, blood return or venous return is normal. If we can't do it by those, the patient has a higher risk of a DVT. So now we add anticoagulants. Okay, so these are your let's, before I forget this part here. So here's the dimer. Again, can you make a diagnosis based of a DVT based on the D-dimer only?
No, Professor, just an indication.
Right, this will just suggest it, right? So let's say the patient doesn't have these symptoms here. Where are the symptoms? Okay, here. Symptoms are unilateral leg swelling, okay, edema, or there's a red streak along the course of a vein, for instance, are your common symptoms. So let's say they don't have that yet. A D-dimer will suggest it because comparing D-dimer against a duplex ultrasound, which one is cheaper?
You said comparing a D-dimer with what?
A venous ultrasound. Which test do you think is more expensive? Well, of course, it would be the Doppler ultrasound now, right? So, whereas this one is simply a blood test. So before you send them for duplex ultrasound, then you order this one. So if it's suggestive, okay, if the results suggest VTE, then you have to make a diagnosis using a duplex ultrasound. Meaning you have to have a visual. You have to find the clot in order to prove that the patient has a clot. So the veins have to be examined and you have to locate where is the clot. Okay. So that's how we diagnose it. Of course, when it becomes a PE, then it'll be a CT, but the PE is in another chapter, so we'll skip through that one. Now let's go to the treatment now. So we have 3 classes of anticoagulants. We do not use thrombolytics, blood DVTs, unless the patient has a massive pulmonary embolus. Yes, we use a thrombolytic, but if it's a DVT, we only use anticoagulants. I already showed you the video earlier of the clotting cascade. So number 1 is vitamin K antagonist. Then we know thrombin inhibitors. That's indirect, because the direct thrombin inhibitor isn't really used for DVTs. And then finally, factor 10A inhibitors, which are your novel oral anticoagulants. They are all listed here. Let's begin with vitamin K. With each one, you have, although not all of them will have routine coagulation monitoring. For warfarin, you have to watch INR at least once a day. So how does this thing work, Miss Kema? Was vitamin K mentioned at all in the video that I showed you earlier?
Which video? The one about the clotting?
Yeah.
Remember, Professor?
Not at all. That's why you don't remember, because they
No.
never mentioned the vitamin K. Now, I asked you earlier, why do we give vitamin K injections to newborns again?
As a prophylaxis against
Because
coagulation.
right, because their liver is not is not mature enough to make clotting factor, right? So therefore,
Yes.
what's the purpose of vitamin K in clotting?
The purpose of vitamin K is in clot to prevent to help with clotting.
Very good. So you need vitamin K in order to make specifically 4 clotting factors. Not all of them, but they affect 4. That's why it says here, since warfarin is a vitamin K antagonist, that's why the antidote is vitamin K. So if you give warfarin, it will prevent future production of clotting factors. So therefore, you have less clotting factors, will you develop blood clots?
Yes.
Again, you have less clotting factors because now you're giving a vitamin K antagonist. You're preventing vitamin K from being synthesized. You need vitamin K in order to make 4 types of clotting factors. So if you give warfarin, is the patient able to make clotting factors?
No.
No. Are they now at risk for developing more clots?
With warfarin?
Yes.
Yes. But don't they give it if you have a clot, they give it so that your blood would to thin out the blood.
So again, so what is your answer? If you give warfarin, does this increase or decrease the patient's ability to form clots?
It decreases it.
Increases it because it's a vitamin K antagonist. So therefore, again, so the long story short, we need vitamin K in order to make clotting factors. Warfarin is a vitamin K antagonist.
Okay.
So no vitamin K, no clotting factor, less ability to clot. That makes
So,
sense?
so that's the reason that they said to avoid vitamin K foods if you're on warfarin, because then it will counteract the effect of the warfarin.
Exactly. Vitamin K is the antidote. So if you're eating green leafy vegetables, you're eating the antidote.
Got it.
Makes sense now?
Yeah.
All right. So other drugs used are indirect thrombin inhibitors. We don't use this one, which is the direct thrombin inhibitor. This is not used for um, DBTs. Okay, so this one, Angiomax, or which is bivalirudin, this is used only most frequently in cardiac cath to prevent clots at the cardiac cath site when they take you in the cath lab. So this is one use of most frequent use of the um, of Angiomax, okay? And also as an alternative, you learn HIT in chapter 30. If you need help with that, just let me know. And as well as argatroban. So argatroban and Angiomax again, more commonly used in cath lab. Argatroban, this is another alternative if the patient develops HIT. HIT is heparin-induced thrombocytopenia, which is a dangerous complication or disorder, really, because instead of preventing clots, the patient develops clot after exposure to heparin. So it's not very common, but the incidence is increasing. We're using heparin more and more. So we're seeing also more and more cases of HIT, which is fatal. So heparin, there are two forms. We have low molecular weight heparin and unfractionated heparin. Both are heparins. Heparin in this instance can be given subcutaneously, but for DBT purposes, these are given IV at a continuous infusion. You monitor PTT the whole time, and you make adjustments to the dose or to the rate of infusion depending on your PTT. The antidote is protamine sulfate. Same thing with low molecular weight heparin. They're both heparin, so both of their antidotes are protamine. Who has given Lovenox? I think I mentioned this in Skills Lab when we were in Skills Lab. Remember I said, where do you administer it? And there's a bubble inside the pre-filled syringe. What do we do with that air bubble? So the answer is nothing. We do not expel that air bubble. Give it directly. So don't worry, the patient doesn't get the air bubble. The syringe is designed already that way. And where do we give it? And I remember in class we said it's given into the love handle, which is the tissue above the area above the iliac crest, which is the love handle. All right. These are both heparin, so the patient will be assessed for signs and symptoms of HIT, which is discussed in chapter 30. So how do we manage the treatment? And after that, we're done. The first therapy is always heparin. The reason is this. Thank you for reading, Zishan. Hello? Or anybody?
It then takes several more days to achieve maximum effect. Thus, an overlap of a parenteral anticoagulant and warfarin typically is required for 5 days. The level of anticoagulation is monitored by using the NUR, which is, I guess.
Very good. So heparin, we monitor PTT. Warfarin, we monitor NR. So if you're diagnosed with DVT today, you will receive heparin first in infusion. On the same day, you will be started on warfarin. The reason is, based on the video here, the Clotting Cascade, remember this is a thrombin, an indirect thrombin inhibitor, heparin. So therefore, it will give you immediate anticoagulation the moment it starts, the patient receives it. However, warfarin affects these clotting factors right here, but it only says warfarin inhibits activation of these clotting factors here, as well as anticoagulant protein CNS. So if you already have clotting factors in the plasma, does warfarin affect those existing clotting factors? The answer.
Professor, repeat that question again.
All right. So we have heparin running. Okay, so that gives you immediate anticoagulation. The moment it hits the patient's bloodstream, it starts preventing thrombin from being activated. Meaning, if you remember the video, you can watch it again. At the point where prothrombin is converted into thrombin, it stops that section right there. It stops that from happening. Warfarin, on the other hand, affects only the activation of these clotting factors, future activation of these clotting factors. So if you already have these clotting factors in the plasma, can warfarin affect those?
I guess, yes.
No, because they only inhibits activation of these. If they're already activated, meaning they're already in the plasma circulating, can warfarin affect those?
Oh, so no, because they're already activated. So
Right. Okay, so warfarin only activates, affects future activation of more clotting factors. If there are clotting factors already in the plasma, warfarin can't affect those things. So that's why it says here, there is a overlap, meaning the patient will be on 2 anticoagulants for about 5 days. So for 5 days, the patient would be on heparin and warfarin at the same time, because it says here warfarin doesn't take effect until 2 to 3 days because of this action right here. Clear so far?
yeah, I got it.
All right. And so throughout, the patient will be on 2 drugs, heparin, warfarin, and then every day, since you have heparin, you'll be monitoring PTT. This one will be monitoring INR. Once you reach 2 to 3, which is right here, your INR right here, so this is your therapeutic level. The patient reaches 2, we can stop heparin. The patient doesn't need heparin anymore because we have reached our therapeutic value. Your
Okay.
INR reaches 2, the patient can be safely put on warfarin only. And so therefore we only monitor INR once a day.
Makes sense.
Okay. If in the rare instance, let's say the patient has a stable clot, they may be put on exclusively on Lovenox only. This one do not require anticoagulation monitoring, meaning it is heparin. However, since this thing has a longer half-life and this is weight-based, meaning the dose that the doctor prescribes is based on the weight. So no matter what the PTT says, the dose does not change. So therefore, is it necessary to monitor PTT when they're on low molecular weight heparin? It's going to be useless.
Yeah.
Yeah, because no matter what the PTT says, the doctor can't change the dose because it's weight-based. Plus, this thing has a longer half-life. PTT has only a 1 to 2 hour half-life. This thing, low molecular weight heparins, lasts about 12 hours. Okay, so they last longer. So they require, they're ideal for outpatient treatment. I mean, the patient can be discharged on low molecular weight heparin only. 10A inhibitors, these are the drugs. Okay. The benefit for these is they don't require routine anticoagulation monitoring, meaning there are no blood tests necessary. There are also no um, diet restrictions. You can eat whatever you want, no blood test required. However, not all of them have antidotes. This antidote is only for Xarelto, and apixaban is Eliquis. Okay, so only 2 of them have antidotes. So if you bleed from the other drug, good luck. Okay, because they have no known antidotes. So as you can see, the blood clot is not dissolved, right? Because we're only giving anticoagulants. Why are we not giving thrombolytics again, Kema?
What was the question, Professor? I'm sorry.
So as you can see, we treated DVTs with only anticoagulants, right? No thrombolytics. Why? Why did we not dissolve the clot? Why are we only preventing new clots from forming?
Why are we only preventing new clots from forming?
Yeah, because as you can see,
Because
there was no there was no thrombolytic ordered, right? All we gave the patient was anticoagulants, which
isn't it because the vitamin K is already activated?
no. As you can see, all the treatments here listed to treat DVT are all anticoagulant therapy. It does not say thrombolytic therapy. Why?
Because she
Based
doesn't
on the
have a
action,
thrombus.
sorry, Zishan?
She doesn't have a thrombus. We're just doing.
Because of
Well, they have a blood
prophylaxis.
clot. Well, it's not prophylaxis because they have a blood clot. They have an existing blood clot. So why are we not again dissolving the clot? Remember the video again? Which was not mentioned actually in the video. So I mentioned this earlier. What's the next step after a clot is formed? What will the body?
Ambulation.
Preventing new ones. Oh, I think.
Oh well, the anticoagulants will prevent new ones from forming. So therefore, the clots that they already have won't get any bigger. So if you remember here on the clotting, I promise I'll let you go. On the intrinsic and extrinsic pathway of the clotting cascade, what happens next after a clot is formed? How is it? Right here. So after a clot is formed, it's also mentioned here. So once a clot is formed, what's the next step?
Not entirely sure. Oh, you're hold on. Assessing circulation. Not sure.
No, right here. You see this, the one I highlighted?
Oh, okay.
Clot retraction and dissolution.
Dissolution
Right. So after a clot is formed, the body will start dissolving that clot on its own.
on its own. Okay.
Right. So all we're doing for a patient with DVT is to keep it that way, meaning don't want this clot bigger because without anticoagulants, this will get bigger and bigger and more clots will form. So therefore, to stop that, we give anticoagulants. So that in a way buys the body time to dissolve the clots that were formed naturally. So there's no need to give a thrombolytic. The body has you covered. But since it takes time, we need to put the patient on anticoagulants because we can't have this clot growing any bigger, nor do we need more clots to form. Did you learn anything today?
Yes, Professor, a lot.
Yeah, I learned.
Okay. Do you want this recording or?
Yes,
I
please.
do.
Okay. All right. I'll send it. Okay. Good luck on class tonight.
Professor, before you leave, this is Debbie.
Yes.
I haven't been able to really get to your information. I sent you my email. I don't know if you saw the message came in. Because it seems as if my school email doesn't work. So I sent you my personal email. I sent you an email to your.
Is it on the chat or is it on my email?
on the chat, and I also sent you one to your school email.
Okay, I'll use those. Okay, the one on the email. I'll
Okay.
save those, and I won't send any more messages through Blackboard. I'll send everything through.
You've been sending messages to Blackboard?
Yes.
I haven't been seeing any of those because I check Blackboard every day, and I haven't seen any messages from you.
Okay. All right. I'll stop.
Next thing, the quiz that you sent, is that supposed to be the one that we were supposed to do at the beginning of the semester?
No, this is just a practice. So I'll give you 3 practices because you have the second dosage calculation exam coming up.
Okay, but I haven't done the first one. I didn't do the first one.
That's fine. This one will do. Do this one, submit it to me. I'll give you feedback, and I'll give you a second one and a third practice. All right?
Okay.
All right.
Okay.
Any other questions?
Thank
guys?
you.
You're welcome. All right. See you next week. I'll keep in touch.
Bye,
Thank you, Professor. Bye.
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 Bye-bye.